So thank you everybody for joining us today for this very important conversation on fatigue. We're going to get started very, very soon. I just want to give everybody a minute to get in. We are expecting a pretty large group today, so bear with us. We're extremely excited to get started with our speaker series for September. So we're a little bit after the hour, so why don't we go ahead? I'm going to start by thanking our sponsors, Annexon, argenx, CSL Behring, and Grifols for sponsoring our virtual education programs. And then I'm going to welcome Dr. Stojan Peric from the University of Belgrade, who is joining us today to talk about fatigue. Dr. Peric is a neurologist and leading researcher at the University of Belgrade in Serbia, and we're going to talk all about fatigue. We have some questions that we're going to get through. I do want to give a warning to everybody. We are expecting a large group with a lot of questions, so we may not be able to get to your questions live. If we don't get to them, please feel free to send them to advocacy@gbs-CIDP.org. And then a reminder that these webinars are meant to be educational and they're not meant to troubleshoot or consult on individual cases. As always, you should talk to your doctor about your care. If you do have a question about the topic that we're discussing, you can type it into the Q&A box at the bottom of your screen. But again, remember, we are expecting a lot of questions. So we're going to do our best, but we may not get to all of their questions, and you can always email them. All right, so with that, we're going to get the conversation started. Welcome, Dr. Peric. Thank you for your time today.
Thank you for inviting me.
Before we kick off the conversation, I actually want to highlight a few things that we at the Foundation have learned from our patient-reported information registry. So our registry, you can learn more about it on our website, but it's a collection of surveys that help us to better understand the patient experience of GBS, CIDP, MMN, and related conditions. We do ask about fatigue and quality of life in the registry, so I wanted to share some things that we found, and a special shout out and thank you to Champ Martinez, our intern here at the Foundation, for pulling some of this data. So I'm just going to be very quick, and then we're going to get right into our questions. So Dr. Peric, I'm going to bombard you with some of these stats, so apologies for putting you on the spot. But across all patients in our registry living with CIDP, MMN, GBS, and anti-MAG, 68% say fatigue interferes with their physical functioning. 72% say they are bothered by fatigue and how they feel physically. And 75% have trouble finishing tasks of fatigue. So these numbers vary slightly when we break it out between the different conditions, between GBS, CIDP, but the overall pattern holds true, where a solid majority are indicating that fatigue is burdensome. Does that surprise you? Do you have any initial reactions to those numbers?
This is usually in line with the numbers that are already reported in the literature. So it is something between 40 to 80% of patients with different type of inflammatory neuropathies to report fatigue. So it's pretty common problem.
Yeah, that's interesting. So I think we should start at the beginning. What does fatigue even mean? What does a person experience when they feel fatigue, and how is it different from feeling tired? Are those words interchangeable, do you think?
Yeah, in some languages, even like in Serbian, there is no different word for this. So we use the same word for both things, but actually these are two different things. Tiredness is a normal thing that can happen to everyone, even to young, healthy persons. So it is something that appears after a long activity, long exercise, or even long psychological activity. And after this, you will take a nap or you can sleep, or after that, you can completely restore yourself. So tiredness is not continuous. It appears sometimes, but it can be better after rest. And on the other hand, fatigue is something that is not normal. It is pathological. It is exhaustion. It is lack of energy that is present not only after activity, but always. And you can sleep, you can have a nap, you can relax and have a rest. But even after that, you still feel fatigue. So this is the main difference between tiredness and fatigue. Fatigue is a pathological condition.
Pathological condition. That's extremely interesting. So when you say pathological, that kind of means like a diseased state. You know, when we think about pathological, that it's indicating disease.
It indicates that it's associated with the disease. It is not disease itself, but it is a part of the symptoms and signs of some disease that patient can experience.
This is maybe a big question, but why does fatigue happen? Do you have any sense of the biology of some of that pathological pathological process that's leading to fatigue?
Yeah, fatigue is present in many diseases, usually in chronic conditions, but also in some acute conditions and after acute conditions, such as, for example, GBS or Guillain-Barré syndrome. And one of the reasons to have fatigue are peripheral reasons. And in neuromuscular diseases, such as polyneuropathies, for example, there are some peripheral reasons to have fatigue. For example, myasthenia gravis is a typical example of disease with a fatigue. And this is disease of neuromuscular junction, the connection between nerve and muscle. And also some other neuromuscular diseases, the majority of other neuromuscular diseases are also associated with fatigue. And these peripheral mechanisms, which means weakness of muscles and impairment of peripheral nerves that affect muscles, is actually a cause of peripheral component of fatigue. But on the other hand, a central component of fatigue is also really, really important, because even in some other chronic diseases without peripheral pathology, we see fatigue. And this is actually our reaction, patient's reaction on some chronic condition. And it is associated with some central nervous system things like a personality, like a life experience, reaction to stress. It can be a kind of a post-traumatic, actually, stress disorder, one way of the post-traumatic stress disorder, because even if you don't have your disease anymore, for example, GBS, this knowledge about having disease in the past can be really burdensome and can cause a fatigue, especially central component of fatigue. So there are different mechanisms, but the main thing is that we have a peripheral one and central ones. And actually, there is no any specific measure how to see which one is more important. We do not have any scale to say, okay, this is a peripheral component and we will treat like this, and this is central and we will treat like this. We don't know. We don't have that measure.
I have so many follow-ups, so please, please forgive me. Did I hear you mention that inflammation might be part of some of the fatigue pathology? So inflammation kind of in the whole body or around the peripheral nervous system or central nervous system? Is there a component there?
It can be. It can be even in some, for example, chronic diseases that are not neurological, for example, metabolic syndrome or obesity. These are the chronic states of inflammation. It is a low-grade inflammation anyway, but it is possible that these different factors like cytokines and something can affect our brain, our muscles, our body, and actually cause fatigue. So it is true that inflammation is one of the factors, probably. But if you want to analyze fatigue in any disease and to make an association with some objective measures, for example, I don't know, sedimentation rate or something even more specific, like a level of interleukins or cytokines, you see no correlation usually. And usually, if you see it, it is so weak, and you cannot say that it is a biological mechanism. And I think the main reason for this is actually this central component of fatigue that is so subjective.
Interesting. So when we say central, you're meaning the central nervous system versus the peripheral nervous system, which is what is affected by CIDP and MMN and things like that.
Yeah.
One more follow-up from that. We often hear from patients that they correlate fatigue in their minds because they have to be so much more mindful and thoughtful about their movements, and that contributes to the exhaustion. Do you think it is contributing to the fatigue? Do you think it causes the fatigue, or are those maybe separate kind of things?
Yeah, what we know actually, and if we look at the statistic, we can see that some impairment measures, such as, for example, muscle weakness that is objectively measured, or sensory impairment, is not in high correlation with the level of fatigue. So as you already mentioned, some patients are in remission. They have no weakness. They have no disability. They have no sensory impairments anymore, but they still feel fatigue. So it is not always related to the impairment of or muscle weakness, but you mentioned something that having less activity maybe is will produce less fatigue, but we know from other diseases, like some chronic diseases that are not neurological, for example, chronic obstructive lung disease or rheumatological disorders or anemia, that physical activity actually decrease fatigue. So uh, especially aerobic exercises can really help to reduce fatigue. We don't have any clinical trials for this in CIDP and other inflammatory neuropathies, but if we learn from other fields, it seems like this can be helpful. So patients should be active.
Should be active. Interesting. It sounds like, and we'll probably talk about this later, but it sounds like fatigue is an area that needs more research attention.
I agree with this.
Yeah.
And, researchers like exact things, like things that we can easily measure with some numbers. You perform nerve conduction study and you see velocity, you see amplitudes, and that is something objective. And when we are talking about fatigue, it is a subjective thing. It is patient reported, and it is not easy to get all information about that. So I think that researchers, because of this, are not so much focused on this.
Yeah, interesting. So we'll talk a little bit later about how patients should be communicating fatigue to their doctor, but let's talk about, we talked a little bit about this, but I think you have some data that you wanted to share about why does fatigue happen more for people living with GBS, CIDP, and MMN than it does in other conditions. And this was maybe my leading question because it seems like it happens more for GBS, CIDP, and MMN. Definitely fatigue happens more for our patient population than the general population, but it seems to happen more compared to other conditions as well. And then you touched on it, but patients feeling fatigue despite describing themselves on in remission. So would love to hear your thoughts on those two things, why it happens in our conditions and why it happens despite patients feeling like they're in remission.
What I can say definitely is that fatigue is more common in these conditions in comparison to general population and healthy people. But what I would like to present here is our data. We reported a lot about fatigue and about quality of life in different neuromuscular conditions. And these patients are actually from Serbia, so it is a little bit different cultural background in comparison to the United States. But anyway, we compared all these disorders in the same cultural background, which is Serbia. And if you look here at the fatigue severity scale, you can see that it is pretty much similar in many diseases that are neuromuscular diseases. So myotonic dystrophy, type 1 and 2, chronic inflammatory demyelinating polyradicular neuropathy, limb-girdle muscular dystrophy, MGUS polyneuropathy, different diseases, but similar level of fatigue and even similar percentage of patients affected with fatigue, like 40 to 60 approximately percent in our population. And what we actually found, although we have 17 patients with multifocal motor neuropathy tested, this is a small number, that fatigue is less pronounced, for example, in this disease in comparison to CIDP, for example. And here are, for example, the results of the quality of life in different diagnoses. measured with SF-36 questionnaire, which is most widely used. And you can see here, for example, that patients with CIDP have better quality of life, for example, in comparison to amyotrophic lateral sclerosis, but very similar to hereditary neuropathy, Charcot-Marie-Tooth, or very similar to myotonic dystrophy type 2 or something. And you can see, for example, that in GBS or in MMN, quality of life is even a little bit better than in other neuromuscular diseases. So yes, patients with CIDP and other inflammatory neuropathies, they have fatigue. It is more common than in general population, but it is pretty much similar like in other neuromuscular diseases. And here we wanted to present different factors that are associated with quality of life in different disorders. And if you look here at the last column is fatigue. And this X means that we did not test fatigue in that group of patients, but in all other where we tested, fatigue was in high correlation with quality of life. And it was an independent predictor, the most important predictor of quality of life, which means if patient has fatigue, it means that his or her quality of life is reduced. It is very, very strong association, and there are different reasons for this. So just to conclude at the end of this topic is that fatigue is really important here, but fatigue is not actually, sorry, did I stop to share my slides?
Yeah, all good. It looks good. Yes.
Okay, I'm sorry. So, but you can also see it in other diseases and patients that besides, for example, CIDP or MMN, have other disorders like cardiologic conditions or anemia or lung conditions, they will have more fatigue in comparison to patients that have only CIDP.
Yeah, this is very interesting of the intertwining of more conditions impacting fatigue. And thank you so much for sharing that data. It's always very helpful, I think, where we can see kind of how the patient populations compare, and also to know that we're not alone in this, that other neurological conditions are also experiencing this. There's strength in numbers in terms of, then how we study fatigue. Can you tell me a little bit about the FSS scale, what that is and what that means?
It is fatigue severity scale that was developed by Krupp. So sometimes we call this Krupp's fatigue severity scale. And there are actually 9 questions. And there is a Likert scale, so you can respond what is the level of the truth for some statement. But what is really important here is actually that this scale was developed for multiple sclerosis. So completely different disorder, which is neurological, but it is the disorder of the brain, not of the peripheral nerves. So we don't have actually a specific scale. There was an intention from the Dutch group, from Professor Merkies, who actually transformed this scale to the RASH scale, RASH fatigue severity scale, which is a little bit different in comparison to multiple sclerosis. And this was validated in a cohort of patients with different inflammatory neuropathies. It was a mix of different inflammatory neuropathies. And it seems this RASH scale is better than the original one if you want to measure fatigue in patients with inflammatory neuropathies. But still, in many cases, we also use the old one, the old scale, because in this way, you can compare fatigue in CIDP, GBS, MMN, and other disorders. And also you can make historical comparisons. Because if you use new scale, you cannot compare your cohort and your patients with the previous results in history, because usually in history, they use this first version fatigue severity scale.
Very interesting. So it's bringing me back to my thought of that this feels like an area of research for a scale specific to our community that better measures it. And this maybe seems like a basic question, but other than patient-reported how people are feeling, is there any sort of biomarker for fatigue? Is there any sort of test that definitively can point to how tired or not tired, how fatigued somebody is feeling?
Actually, we don't have a biomarker. In some disorders, such as myasthenia, which I mentioned, you can perform some specific needle EMG study, electromyography study that is called repetitive nerve stimulation. And the decrease of the amplitudes of motor potentials actually is a measure of fatigue. And that is an objective measure of peripheral fatigue in that disease that is myasthenia gravis. But for CIDP, we don't have a measure of fatigue that is a biomarker or objective measure.
Okay.
Same thing is with the pain, for example. You have to believe to your patients that they really have a problem that is subjective, but they can measure it. They can say, I feel like 50% fatigue or something. So you can measure like that on some visual analog scale or using fatigue severity scale or some other measures.
Right. So that's what's interesting about those questionnaires is that, they're not kind of developed overnight. They're developed and tested and evaluated on how well they measure these things based on clinical. So they do go through a lot of scrutiny, right? These scales that measure fatigue and that measure pain.
That's true. They are very, very useful.
Yeah. Okay. Um, the reason I asked about the biomarker is because we had some people write in early and say that their fatigue comes and goes, kind of similar to their other symptoms of weakness or numbness. So specifically thinking of CIDP, any thoughts of why that fatigue may come or go with their other symptoms?
Yeah, we analyze the fatigue during time. For example, in patients with CIDP during a 1 year period, and we see some patients that changed. So they have fatigue, and on follow-up, they lost it, and vice versa. So there are some changes, and what is really important here, these are not in relation with the change in disability or in weakness. So it's something different. Some patients are better regarding their disability, but still they have worse fatigue. And if you look, for example, in GBS, we tested our patients, and for example, at day 14 and day 28, they have less pronounced muscle weakness because they were treated, but still their fatigue was very, very high. And they needed like months to have fatigue decreased, although they were completely rehabilitated before. So it's something different, and it is possible sometimes that we will find a biomarker of this, but at the moment, unfortunately, no.
I think patients would like a biomarker to help validate their experience. And something that you said that was very interesting to me was that the fatigue is not a measure of somebody's disability. I think that's very important because that can come and go. And I think it's important that we recognize that, and especially just thinking as the whole patient and being mindful of what you're doing to treat your CIDP. That was a very clumsy transition into me asking about IG therapy. We also had a lot of people write in and ask about feeling wiped out or feeling a lot of fatigue after receiving regular IG therapy. So again, this is more on the CIDP and MMN. We know our GBS patients also experience fatigue long-term afterwards, but let's look at the IG therapy treatment and people feeling fatigue after that.
Yeah, if, for example, a person with CIDP or MMN have good muscle strength and no disability, and he reports fatigue, that is not the reason to increase the dose or to treat more frequently with IVIG for several reasons, because you will probably not improve this. In many papers, actually, we showed that treatment with IVIG will not improve fatigue. And in some instances, you will see, even if you treat too long, that patients will be more fatigued because the treatment is burdensome. They have to come to hospitals or infusion centers more frequently. So this therapy even can produce fatigue. So experts in the field just reported it is an official recommendation that our treatment with IVIG or other therapies should be based on muscle weakness, and not only muscle weakness, but some impairment measures that are objective, and disability measures, such as, for example, IROD scale or INCAT scale, that patients are usually familiar with because these are widely used. So presence of fatigue is not a reason to start treatment, and absence of fatigue or decrease of fatigue is not a reason to stop treatment if patients still have disability and weakness.
Yeah, that's interesting because sometimes it is maybe the only symptom that patients are feeling. So it sounds like that patients can be moving to remission, feeling as if they don't have weakness or disability, but they have fatigue. So that it's kind of tricky and confusing for patients, don't you think?
It's tricky and confusing, and it doesn't mean that fatigue should not be treated. There are other options that are probably much better, and this should be discussed on an individual patient basis with the physician. And it means that we found different factors that can affect fatigue in our clinics, but also in the research. So I already told you that a kind of a personality of patients, life experience, and the way of coping with disease is really important. But besides these psychological moments, there are some more physical things like sleep, because the quality of sleep and daytime sleepiness are really, really important for fatigue. Then the presence of depression and anxiety. So there is some overlap. Not all patients with fatigue have depression, not all patients with depression have fatigue, but there is a huge overlap. So in some cases, you should treat depression or anxiety and you will improve fatigue. Also, pain is overlapping with fatigue, so you can use neuropathic pain medications, for example, in some patients in order to improve their fatigue. Also, I mentioned other diseases that should be treated. If patient has anemia and CIDP, he will be more exhausted with more fatigue, so you can treat this. Metabolic conditions, including presence of diabetes, obesity, even glucose intolerance, are also very important factors that can be treated. Physical exercise is really important, and we know from other diseases. For example, several years ago, in other neuromuscular condition, clinical trial was conducted about cognitive behavioral therapy and exercises. It is myotonic dystrophy type 1, and this was really helpful. And the main effect actually it made in patients is that they had less fatigue. Actually, this was the main outcome that patients reported as a good thing of cognitive behavioral therapy, and exercises actually was improvement of fatigue. And what is also important is the different medications that are used can produce fatigue. So you should actually reduce some drugs, especially benzodiazepines, that can produce a lot of fatigue and that are, for example, in Serbia, very widely used. Also opioid drugs, also alcohol intake, and even caffeine intake. A lot of coffee can also produce fatigue, although temporarily we think we feel better and with more energy. So there are different things that can be done to improve this condition. And the treatment with IVIG will not help, I'm sure.
Yeah. What I'm hearing is so interesting in that we want to make sure that we're taking care of the whole patient and not just the patient's CIDP or MMN or their GBS. We want to make sure that every other system in the body is working well and kind of getting us healthy enough to try to start to reduce that fatigue. And CIDP might only be one piece of the puzzle. Does that seem like a fair summary?
That's true. That's true. We should think about other things. And in some cases, if you're not sure, we should include other specialists in the treatment of the disease, especially psychologists or psychiatrists if needed. And in many cases, it is needed. So I agree with you completely. It's a holistic approach to patient.
Yeah, a whole person approach.
Yeah.
And we're getting some questions in here, so I'm actually going to jump over. I see one about long COVID and fatigue, and there was, I think, a couple studies that patients who have autoimmune conditions are more likely to experience long COVID, and then fatigue is big in that. This is kind of bringing me back to the whole person treatment of fatigue, but wanted to see if long COVID stood out to you as a topic to discuss.
Yeah, it's true that it is possible that this condition can be present, but it is not only related to COVID. We know from before that other viruses like Coxsackie virus, like flu, adenoviruses, and other viruses can produce this condition. And I already mentioned that this is probably a low-grade inflammation, a low-grade immune response that is present in these patients for a long period of time, for months or for years. And this can affect their quality of life significantly. And what is important, doctors usually do not believe to their patients because there is no biomarker and there is no objective measure of their problem. But also in these conditions, because they are very, very similar to what we already talked about, is that aerobic exercises, swimming, cycling, and things like this can really, really help. And in some cases, some antidepressant drugs that can help also in this condition.
Thank you for calling that out. I see another question here about HGH, which I think is human growth hormone supplements. Do you know of any HGH or human growth hormone research about fatigue?
I really cannot recommend this because also in Serbia and in Eastern Europe, people are using this, a lot of people with neuromuscular diseases, and we do not have any trial to show the effects of this. So I really cannot recommend this to anyone because we don't know if it is efficacious and we do not know if it is safety for this patient. Safe, I'm sorry.
Yeah, thank you. And as a reminder, all of these are educational, so don't make any decision without talking to your doctor, especially when it comes to supplements. So speaking of research, and we've talked a lot about IG might not be the treatment for CIDP that ever helps to reduce fatigue, but there is a lot of clinical trials happening. There are a lot of clinical trials happening globally looking at potential new therapies to treat CIDP and to treat MMN and potentially to treat GBS. Do you have any sense of any of the new therapies and clinical trials or any of the new pathways being targeted to treat these conditions, if they will eventually help fatigue?
Actually, there are a lot of clinical trials, as you said, but all of them are actually the two types of drugs. A group of drug is FcN blocker, and another type are complement inhibition. So they're basically very similar. You have two groups, not 22. But in all these trials, main measures that are used are actually disability and weakness usually, and you will see the results, how it affects this. And there are some secondary or tertiary outcome measures, including fatigue and quality of life. So we will also see this. Some of these drugs, for example, helped really to treat fatigue in myasthenia, for example. So because this is the main feature of the disease. So it is also possible to help in CIDP, but we will see. I'm not sure that fatigue will disappear because we will need also other things that we mentioned.
Yeah, so this is a plug for the Foundation's research portal on our website to learn more about those clinical trials. But as Dr. Peric was saying, most of the time, those clinical trials are measuring disability and that weakness and how people are moving based on whether they take the drug or not. But we're very happy to be working with our industry research partners to bring the patient voice into that process. And the reason I asked is because fatigue is one that we always hear from the patient advisory boards of something that does impact the day-to-day life and that they would love to see more research on. So I'm thank you for taking that full circle with me there.
Almost, I'm sorry, in almost all trials that I was involved in, like a treating physician, we measured fatigue. This is not the primary measure, as I said, but it is always important, and it is at the end, it is always reported.
Absolutely. Thank you for clarifying. So let's see. Any medicines that can reduce the impact of fatigue and or any supplements with, again, the reminder that nobody should be taking supplements without talking to their doctor first.
Yeah, I'm really sorry to say that there is no specific drug for fatigue. So as I already mentioned, even some drugs can produce fatigue. So sometimes the treatment of fatigue is to reduce this drug and not to introduce new ones. So we don't have a specific drugs.
Yeah. I'm remembering that you said earlier that aerobic exercise is also important. So sometimes that can be just prescribed as medicine.
That's true.
Yeah. What about diet or any food like that? Processed food, avoiding processed food, anything like that?
No data on this, but I believe that using Mediterranean diet is always good for every condition because, for example, there were some reports from, for example, from Italian group recently in European Journal of Neurology, which is a very good journal, that, for example, people that eat white bread, have higher risk to develop CIDP in comparison to people who eat rice, for example, or people who eat fish are protected from developing inflammatory neuropathy such as CIDP. So I really think that these good dietary habits are important, and eating rice and fish, we know, is really good for inflammatory neuropathies, for example, if we look at the literature.
I love this ties in, to some future programming that we are going to be doing on nutrition. So stay tuned, and thank you for the little teaser there on healthy eating. When we think about patients talking to their doctors about fatigue, how can patients effectively convey fatigue to their doctors? Like you said, there's no biomarker and there are some scales, but not all physicians might feel as comfortable using those scales or might not be as familiar. So how do you recommend patients empower themselves to bring up fatigue as a major concern to their physician?
Yeah, what I'm doing with my patients is actually that I stole an idea from the group of headache. So headache is something that is also subjective. And my colleagues from the Center for Headache, they use a diary for patients with certain questions like, did you have a headache? Which type of headache? Did you use some medication at that day? So you can use a similar diary for fatigue. At the end of the day, you can scale the level of fatigue you had. It can be just a simple barometer scale, like from 0 to 100%, which is the level of your fatigue that day. And then you should probably write which areas of your life were affected with this, like activities, social relations, then your emotions, maybe even your body image, etc. Different things. You can have a list from different questionnaires. And at the end, during that day, you should ask your patient if they have a good sleep the night before, which medications they took, did they have some stress at work or at home, etc. There is a reasonable list what to include, like 5, 6, 7 things, not everything. And you can do this for example, a month or two. And after that, you can go through this diary and make some conclusions. What is the level of fatigue? Which domains are affected? and which potential factors can produce this. Like maybe in some CIDP patients may think that produce fatigue is actually a stress at work. So you will advise how to reduce this. Maybe sometimes it is taking a benzodiazepines, or sometimes not enough sleep during night, different things that you can capture with this approach, and you can fix this.
I think that's a great recommendation. And we held a program about communicating for success at the doctor's office, who also recommended keeping a list or a running diary of kind of these things going on, and not only the symptom, but how it impacted and disrupted somebody's life. So I love that you're implementing this into your practice, and I hope that it starts to catch on. Relatedly, we got a question from the audience from somebody who is pointing out that sometimes they feel a weakness in their arms or legs, but when the doctor examines them, there's no weakness present from their exam. Do you call that maybe a type of fatigue, that they feel like it's weak in their arms and legs, but the weakness isn't there on clinical exam?
I would say that it is normally to have some fluctuations. For example, even healthy people have this. So during the day or from day to day, you may feel a little bit better or less better. But what is also important here is that we have some scales, like we used Medical Research Council scale for muscle strength, and it is 0 to 5-point scale. And it is possible sometimes, if patient is really strong and go to gym, that he can see something, that his strength is reduced, and I cannot measure and I cannot capture this. So I would believe to my patient, and I will check him more frequently. Even other scales like Inca Disability Scale, for example, if your patient can walk without any support, it is the highest degree. It means that legs are completely normal. But on the other hand, your patient may say to you, I cannot run. And you cannot capture this with this scale, or I run slower. So it is true that we cannot capture everything with the scales, but scales are pretty good because we can compare different patients in different situations, and we can show the efficacy of certain drugs in this way. But yes, it is true that patients can feel something, and it is objective problem, but we cannot capture this with the scale that we have.
Again, I think of the biomarker and the research into some sort of biomarker to measure disease activity for GBS, CIDP, and MMN, and also to measure fatigue activity or weakness activity would all be very interesting to eventually have in the future.
That's true. That's really important.
What about the care partners for our patients when somebody's experiencing fatigue? Do you ever have advice for the care partners and families of the patient who are helping to support this person, or do you have advice for them on to help them manage the fatigue?
I was looking a lot in this sphere, trying to find an answer to this question. And actually, there is no paper that showed that social support can reduce fatigue. So nobody actually tested this. But on the other hand, what we know in many diseases, including neuromuscular disorders, is that social support, perceived social support, not only from the family members or caregivers, but also at work and with other people, with neighbors, can affect patients' quality of life. So it is really, really important, I'm sure, and should be further researched in the future. But I believe that the main support that they can gain for their caregivers is actually to motivate them to be active in exercises, but also to go to some leisure activities, to visiting their friends, family, go to theaters, not to sit at home and think only about the disease, but to be active in many ways. And this is really important and can be supported by family members and caregivers.
I think that leads us to the last question I had, and then we have some questions from the audience we might get to. But the last question I had, we've touched on this a little bit, is the impact on mental health and fatigue. So you were saying, helping people kind of stay well overall, that includes their mental health. You talked a little bit about cognitive behavioral therapy. So I would just love to hear your perspective a little bit more on the link between fatigue and mental health. And if you can clarify cognitive behavioral therapy a little more, CBT therapy for the audience.
If we look at the quality of life results in patients with inflammatory neuropathies, we see that both physical and mental components of quality of life are affected, although this is disease of the peripheral nervous system, not of the brain. So it is true that there is some reaction on this peripheral condition that is central, and mental health is really, really important. So I already mentioned that a kind of fatigue, apathy, depression, anxiety can be present in these patients, and this should be treated in a particular way, sometimes with the help of a psychiatrist and psychologist. I'm not an expert for a cognitive behavioral therapy at all, but I know that this really can help, and we have a psychologist that are involved in this. And I suppose that every center that dealing with patients with neuromuscular diseases should have a psychologist.
I love that recommendation. Thank you very much. We have some time left, so I'm looking through some of the audience questions here. We're hearing quite a few questions or comments of people who are struggling because they feel it's really hard for them to get started with physical activity. So we're seeing that in the research, increasing aerobic activity can help be a treatment for fatigue, but people are really struggling to get that started. Are you aware of there's a threshold or something? People feel really exhausted at first when they start doing exercise and then start to feel the benefits, or anything like that? Can you elaborate?
I believe they should start very slowly and then increase the level of their activities step by step, very, very slowly, especially those that have a significant weakness, that are non-ambulatory, etc. It should be step by step.
Yeah,
But
so taking
certainly,
maybe a physical therapist or a physiatrist.
I think the way that we are doing here in Serbia is that physiatrist is the first who see the patient and then make a plan what to do. And then physiotherapist is doing what is prescribed with the patient, with the patients, of course.
Yeah. So it sounds like it can be hard to get started. It can be scary and exhausting to get started. So start slow and take it easy, knowing that the results are going to be a long-term thing. It's not necessarily an immediate fix.
Yeah, it's something like really start low and go slow, really, step by step.
Step by step.
And I understand this completely because I'm not somebody who is really into exercises, so I know it's a problem to start. I have a psychological preparation to start anything, but at the end, it is really useful for everyone.
Yeah, yeah. And it can definitely be hard to feel motivated to start when you're already feeling fatigue, right? So it's even an extra burden. You feel like you're weighed down and getting started. So low and slow, like you were saying.
Slow and slow. And in this way, you will get more oxygen for your nerves, for your muscles, and for your brain, which is really important.
Yeah, interesting. We've heard anecdotally of aqua therapy or doing water exercises and things like that, especially for people who have pain. Have you seen that at all in your patients?
I think that majority of our patients reports that aquatherapy can help because in water they can do some movements that are not able to do in air. So I think it's really useful to start with this if these things are available, but it is not always available in some small towns or in villages or etc. But what I have to say, here in Serbia, we have a lot of thermal spa, And this hot water is not so good for this condition because it is inflammatory condition. And like in other disorders and multiple sclerosis, etc., I believe it can even worsen the thing. So aquatherapy, I believe, is really good, but not with the hot water.
Very, very interesting. And thank you for that clarification as well. Um, what about acupuncture? And I know acupuncture pops up in the literature a good bit. Do you have any familiarity with acupuncture in treating fatigue?
No, I don't. I do not do this, but some of my patients were better regarding their pain with acupuncture. And about fatigue, I cannot say this. And yeah, maybe it should be
Yeah.
tested in some
Yeah.
trial. But for pain, I think it can help.
Well, we have lots of things to add to our research on fatigue portfolio here. So I hope we have some people getting inspired.
You make
Yep, sorry, go ahead.
you make notes what we should do in the future.
Yes. Well, the first note I made was that everybody should get a swimming pool in their yard. You mentioned oxygen as part of the exercise, and we got a question then from hyperbaric oxygen chambers. Have you seen that at all?
Everyone in the last, I think, 6 months at least, or maybe a year, every patient with different diagnosis is asking about this. So, and I do not have an answer. I just say that there is no evidence that this can help. And I may be a little bit afraid because this can produce additional oxygen that can produce oxidative stress that can be maybe even problematic for some cells, maybe for nerves. I really don't know. This should be further investigated.
Mm.
It has its role in some diabetic conditions, of course, but for inflammatory neuropathies, I don't know what to say. And we should test this in the future better.
Yeah, interesting. And the oxidative stress, I think, is a good point, and people should be aware of that before they start any sort of therapy like that. And of course, don't forget that all of this is for educational purposes, and make sure you talk to your doctor, especially about things like that.
Thank,
Um,
thank
yeah,
you for mentioning this several times because it is really important. And it is really hard to give any advice regarding supplements and some off-label therapies. I don't know. It's really hard to say.
right, right. I think I'll do one more question because I think this is interesting, and we've seen a lot of these come through, and hear a lot about this. This is the GBS community. So people who had GBS 10, 15 plus years ago still experience fatigue and sometimes weakness. Is that common from what you see for GBS patients years and years after their GBS diagnosis and experience to still experience fatigue?
Regarding weakness, they may have it because they may have some that we call residual neurological deficit. So not everything improved after acute phase of GBS. So they may have this weakness that is long lasting. On the other hand, even patients that do not have this weakness actually may report they have fatigue or some tingling or some pain. And yeah, we as doctors do not think a lot about this because, I perform neurological examination and see the strength of all muscles is perfect. They just say, you're great, you should be happy. And yes, but patient insists on the presence of fatigue. And we see this even 20 years after GBS. And in some papers, it was reported that up to even 40% of patients after 20 years of acute GBS episodes still have some kind of fatigue. And this is probably at least partially related to these central things, like it is a life-threatening condition in comparison to other diseases like CIDP, MMN, or MGUS neuropathy, this is really life-threatening. So if you had this, it is a real trauma. So this is post-traumatic stress disorder. Like you had a war or something like this. So this psychological component, I'm sure here is really, really important.
Yeah, that is very important. And thank you for highlighting that and helping some of those patients out there asking those questions realize that they aren't alone in this experience and that people like you are and us that we're aware of it. Dr. Peric, I want to thank you so much for this conversation. This has been fascinating, and I hope our audience also enjoyed it. Some of the things that I took away are to make sure that when you talk to your doctor about fatigue, you're also talking about how it impacts your life and, you know, the social things that you're missing, the work obligations that you're missing, so that your doctor can help you find the whole person solution to why you might be feeling fatigue and look at the whole person. And maybe it's not just the CIDP causing the fatigue, but maybe there's other things going on and the CIDP is exacerbating it. And you also really emphasized many times the importance of mental health with fatigue and making sure that you are taking the steps necessary to have good mental health and that it might help to improve your fatigue. Dr. Peric, were there any other final notes that I missed that you want to make sure the audience remembers?
At the end, I would like to say that I really tried to be in between patients and doctors, because patients, they are sure that their fatigue problem is really objective and measurable, and doctors that believe that this is not too important, but the truth is something between. It is important, it is present, but it is not always related to the physical things. So I think that that is the main message. And I think if you think in this way as patients, you can improve your state.
Yeah, absolutely. And thank you for educating us on the FSS, the Fatigue Severity Scale. I think people are going to be Googling that after this. So that's a great tool and resource. And there's lots of areas for research in the future. And I hope that we will see more of each other and talk more about the potential areas of research.
Thank you very much.
With
I
that,
really enjoyed.
yeah, I can't thank you enough. This has been very interesting for me, and I hope so for the audience as well. So this was recorded. It will be shared with our audience, whether they attended all of it or some of it. Another thank you to our sponsors for sponsoring our virtual education programs. We had a lot of questions come through. I know our team did the best that they could to answer them live. I did the best I could to throw some of our questions in there. But if you have remaining questions that you would really love to get answered, please email them to advocacy@gbs-cidp.org, and we'll do our best to get them answered. I might be bothering you for some of those answers, Dr. Peric. I hope that's okay. And with that, we hope to see you next month. Before that, we hope to see you at our virtual summit, which is at the end of this month. And then please make sure you visit our website for our list of centers of excellence, support groups, all of the education that we have on our website. So Dr. Peric, one last thank you very much and have a great rest of your evening.
Thank you.
All right, bye-bye.